There we go. As Janine said, I'm going to be talking about telemedicine and bridging clinical gaps by using technology and local resources. Next slide. So, my name is Sally Dwyer, as she said. I am the Director of Mission Strategy for the Mid-America chapter of the ALS Association. I work out of the Kansas City office, and my job as Director of Mission Strategy is to direct and supervise the chapter's mission, which consists of care services, programs, staff, and partnerships, advocacy and public policy, education and awareness, and chapter support of research. Next slide. Just a quick mention about our chapter. We started in 1978, and actually we're 41 years now, and we serve 3 states, highly rural states, as you can see and as you know, with 4 offices and 6 clinics. Next slide. For this presentation, I will provide some background information on the current ALS clinical landscape, and I'll show how our situation in Wichita demonstrates the challenges that many of us face in providing clinical care. Additionally, I'll discuss strategies for identifying potential clinical partners, plus the necessary legal documentation regarding these partnerships. I'll talk about the technology and equipment that we needed and the help we received to make all of this happen. I'll talk about the clinic functions, how it functions, utilizing technology and local resources. And we'll conclude with a short video of the remote and local team interaction, and then have some time for questions at the end. So as we all know, telemedicine is not a new option in clinical care. The first uses of telemedicine to transmit video, images, and complex medical data occurred in the late 1950s and early 60s. In 1959, actually, the University of Nebraska used interactive telemedicine to transmit neurological examinations. And this is actually widely considered the first case of real-time video telemedicine consultation. Currently, there are 10 ALS Association chapters that are involved in various telemedicine, telehealth programs. Next slide. So although this presentation is about telemedicine, it is also a case study of the challenges and successes we experienced in an effort to bridge clinical gaps and bring the multidiscipline experience to those underserved in our service area. In the end, telemedicine wasn't actually the solution to our problem. The real solution was the engagement of the community in planning and providing telemedicine. Next slide. If we take a look at the ALS clinical landscape, nationally there has been growth in the clinic network. There are 65 certified treatment centers, 22 recognized treatment centers, and 68 affiliated clinics. Yet there are still many areas of the country that are clinically underserved. We recognized that this was happening in our chapter, so we set out to change things. And it was a journey, and not always an easy one. Next slide. And for various reasons, this journey took 6 years. During this time, we assessed needs and funding options. We identified partners, an ALS neurologist, a multidisciplinary team, and a site for the clinic. We compiled partner agreements, and we assembled required technology and equipment. So assessment of needs. So our chapter started with 1 clinic, and it was KU Medical Center. And as we added others, we knew how very important this clinical care was in helping our ALS families maintain quality of life, and for many, extending life. The challenge is that the Mid-America chapter service area is highly rural. As you can see, Nebraska and Kansas each have 1 clinic located on the very eastern border, leaving much of the state in need. Clinical care is more available for those in Missouri. In 2012, we began looking at clinical options in central and western areas of Kansas and Nebraska. we were serving about 180 ALS families in Kansas, many of whom were unable to access clinical care. So there definitely was a need, and we decided to focus our efforts on developing a clinic in Wichita, Kansas. Next slide. So as you may or may not know, surviving family members of ALS are very good at telling the story of ALS. And this was true for two women who shared their story at an event with potential donors. They spoke of their experience driving their husbands the 3+ hours from Wichita to Kansas City, and how very hard it was, especially when ALS progressed. These two women eloquently expressed their frustration that there was no multidiscipline clinic in Wichita, and their hope that someday there would be. And after that event, they continued to tell their story, and the resulting funding eventually allowed us to move our efforts forward. So identifying partners. Well, truthfully, at first, identifying partners in Wichita was a huge obstacle. The main hospital was in transition, so neurologist options weren't there. The few other neurologists around Wichita, including a private practice neurology group, were either not interested or capable of facilitating a clinic at that time. So we were unable to identify an ALS, what we call champion. As for the team, a well-regarded rehab group with allied professionals was interested but unable to collaborate. And the same was true for the two main medical facilities in Wichita. So at this point, we wondered if a clinic was even possible in this area. But then several factors came into play. Next slide. I'm sure you've heard the expression, the answer can be found in your own backyard. Well, fortunately for us, Dr. Richard Barron, longtime ALS clinician, researcher, and medical director of our first clinic, saw the need for clinical services in central Kansas. Perhaps it's because he witnessed firsthand the challenges that his patients faced in traveling hours to get to the one and only clinic in Kansas at KU. Or maybe it was because he heard me whining about not finding a neurologist to champion a clinic with us. Or maybe it was because even though he really didn't have the time to make a new commitment, it might be possible if he didn't have to leave his office. Anyway, and thank goodness, he volunteered to spearhead the project to bring telemedicine into Wichita and to act as clinical director for the new clinic. Quite frankly, we were shocked when he offered that. After all, he's located in Kansas City, 3+ hours from Wichita, and was the chair of neurology and vice chancellor for research with very little time, extra time on his schedule. Next slide. But then he gave us that aha moment. He suggested that the clinic could happen via telemedicine. He could be remote, and our multidiscipline team could be local clinicians from Wichita. As he put it, it's the team that needs to be on site with the patient. It's a novel way to look at telemedicine and a structure that could be replicated in other underserved areas of our chapter and, in fact, in the country. And this aha moment has gone viral. Other disease entities are interested in this approach, which addresses the challenge of not having enough neurologists, especially in rural areas. Next slide. After securing Dr. Barron as our remote physician, our champion, we focused our attention on assembling a local Wichita clinic team. As mentioned, most telemedicine models have the provider at the remote site, so this was a little different. But a well-respected company called Phoenix Home Health and Hospice had worked with many of our ALS families, and though an unusual candidate as a clinic partner, Phoenix was quite interested. They are a give back to the community company and were willing to provide a nurse and physical, occupational, and speech therapist to the clinic team at no cost. And in fact, as a home health entity, they cannot charge for services outside of the home, something to keep in mind. Then we reached out to a company called Broadway Home Medical And to our excitement, they too were interested in partnering to provide respiratory therapy to the clinic team. They also wanted to do it at no charge. Now, just a side note, we did make the decision to pay a monthly amount to both companies to add value and sustainability to the partnership. Next slide. While we were assembling the team, we began a series of meetings with the telemedicine departments at the University of Kansas Health System in Kansas City and in Wichita. They were more than willing to help, and boy, did they ever. They helped us with a HIPAA compliance software we needed called Zoom, which is what we're using today, used for remote connection. They helped us know what equipment we would need to purchase. And at our first clinic, which was a trial run, they had a team of 6 programmers on site to help set up and be sure that everything was good to go. Also, we were very fortunate to find a medical office building in a good location that had availability at least 2 days a month, which is what we were looking for. Next slide. So all of our partners were identified, and although we had discussed at various meetings what everyone's role would be in this new venture, the next step was to document expectations. Probably the more challenging elements in establishing a clinical partnership are the legal agreements. The memo of understanding is a type of agreement between 2 or more parties. It expresses convergence of will between the parties, indicating an intended common line of action. The business associate agreement, or the HIPAA business associate agreement, is a contract between a HIPAA covered entity and a HIPAA business associate that is used to protect personal health information, PHI, in accordance with HIPAA guidelines. Well, thanks to the ALS Association's regulatory healthcare attorney who works with ALS Association chapters, the completion of our five partnership agreements was only slightly painful. Speaking of partnerships, our National Association staff were very helpful in helping us navigate all of this. Next slide. So I've talked about the people and the places that we needed. And this is a list of the equipment and technology that was needed to start this clinic. From a secure recharging storage station, because we didn't want to transport our equipment and technology to and from each clinic, to the iPad used for communication with Dr. Barron, to the rolling cart for the iPad we now dub Robo-Rick. All of these and the others listed come together on clinic day. Next slide. Next slide. And finally, typically people in rural areas experience barriers to participating in research. But for those who attend the Wichita Telemedicine Clinic, not only do they receive multidiscipline care, planning, and symptom management, they are also provided research opportunities. With the help of a research coordinator from the School of Medicine in Wichita, working with Dr. Barron, the drug memantine is now being trialed and others are being planned. Next slide. So this project that was long overdue and long in duration taught us several things. Think outside the box. The game changer for us was thinking about doing things in a different way, using telemedicine to connect the doctor and the local home health clinicians. To be honest, if Dr. Barron hadn't suggested telemedicine, or if we hadn't looked to the local clinicians as a potential clinic team, we would probably still be struggling. And yet here we are, a year and a half and 80 clinic visits later. We do have ALS champions who can help us. We just need to ask. Community resources are out there. We just need to engage with them. Survivors can be major motivators. And finally, technology works and is getting better every day and will be crucial in helping us serve the ALS community in the future. Next slide. So here's a kind of the outside of our telemedicine clinic. The clinic meets the second and third Thursday each time with 4 patients per session. So far, we have served 33 patients, and that's really not showing it quite correctly on there. And we have facilitated 80 patient visits. So that's a little bit not quite correct there. Next slide. We knew that when the, go to the next slide. We knew that when the word got out there was that there was a clinic in Wichita, many ALS families would be interested. So it became important to set up criteria for determining scheduling order and to ensure that patients are seen in a timely manner. So first of all, we said that for someone to attend this clinic, they need to be an established KU patient with actually records at KU. Next, they need a diagnosis confirmed at KU. And third, next in line would be those who are actually due for a clinic appointment. You can go to the next one. Preparation for Thursday's clinic starts on Monday. On Monday, each of the patients is called. Pre-clinic evaluations, sometimes the survey, the FRS, the functional rating scale survey is given over the phone. And the results of those pre-clinic evaluations are sent to the remote site so that they are ready for the clinic. On Tuesday, thinking ahead of the next clinic, letters are sent to patients who are scheduled for that next clinic in 2 weeks. On Wednesday in the afternoon, it's necessary to go over to the site where the clinic is and set up, plug in all of the equipment and be organized and ready for Thursday. Next slide. On Thursday, there's a Zoom meeting with all of the team together. The clinic team meets with patients then, and then Dr. Barron and the team meet with the patients together. And then on Friday, documentation goes into our database, which is called Donor Pro, and orders are reviewed from the neurologist and sent to patients and providers as needed. Now, regarding patient documentation, KU uses Epic, and so we had to adapt and develop our own documentation form to be scanned to the patient record. So here's a picture of Meet Robo Rick, Dr. Barron. Patients love this. It adds a personal touch, and sometimes they'll see a split screen, as you see on the left, with the coordinating nurse and the doctor, but most of the time it's just the doctor. This is just a look at the clinic layout, the patient rooms. There are 4 adjacent rooms that we use at this site. Next slide. This is the team room with a team that meets with the physician, with Dr. Barron for pre-clinic conferences. And that is where we house our equipment. And you can see in the back there is the storage container for all of our equipment that is secured and plugs in. This is a slide showing the clinic flow. From 8 to 8:45, pre-clinic team conference occurs, and while that is going on, the nurse checks in patients, the vitals and weight. From 8:45 to 10:45, so for the next 2 hours, the team members consult with patients, and you can sort of see the scheduling there in the 4 exam rooms, how we work through that schedule. And then from 10:45 to 12, Dr. Barron and the full team consult with the patients, and everyone weighs in on their part and really gets a full look at how the patient is doing. And then the interaction, just to mention that, as you can see, they're talking to Dr. Barron via the technology, and it's really just as good as in person. It's easy to hear and see and communicate. So then the next slide shows a little bit more of that. What's great is that Dr. Barron interacts with each discipline, but also hears how the patients feel they are doing. So the communication really is excellent in that. Next slide. As we do with all of our clinics, we provide patients that attend a satisfaction survey to complete, and we get a really high percentage of these back. It is great to have these. We share these with the clinic team so that we know how to make improvements. And it's all kinds of questions are asked, and then some open-ended ones to sort of see what do they like most and what did they like least about the clinic experience. All right, and so we'd like to show you a video now. Sherry, you think we can do that? That kind of shows the workings of the clinic. Oh dear, the sound is not on, is it? Maybe it looks like we won't be able to see the video, Janine?
I'm trying to get it back there. I'm not sure if you'll be able to hear it from my end. And I haven't stopped sharing. I don't know where it happened. Here, let me go back.
Okay. I hope we can have an opportunity to see this because it really does give you an indication of how well this works.
Okay, I'm going to try it one more time.
Okay.
Let me know. Well, it went to the next slide.
Here we go. Turn it up a little bit, please.
I think that's as loud as.
We've talked about this with the ALS Association for years. We just needed more experts, physician experts in ALS to help manage the patients.
Sherry, if your speakers are movable, maybe you could move them closer to your mic.
And while it may not be that difficult in the early stages of ALS, as the disease progresses, it's really a challenge.
Right. I just want you to know I appreciate you. This has been so helpful for me. And it saved our family a lot of back and forth to get you managed on our own people. We're in the country a lot of fun.
And so the ALS Association, who were a big part of that, what they did on their end, they helped put together the health professions team down in Wichita, which is the speech therapists, the physical therapists, occupational therapists, respiratory therapists, social worker, nurse, and they were able to find those health professionals that in Wichita, and then I'm in Kansas City, and the patients come in for their clinic visits, and we do iPad to iPad through Zoom, and I'm sitting there in my office here with my nurse here in Kansas City, and we're interacting with the patient. I'm having all those therapists that I mentioned do their pulmonary exam, strength exam, chewing and swallowing and feeding exam, and they're reporting to me in real time. And so we're basically all in the room together and making these real-time decisions for what to do with the patient. It's amazing. How are you doing today? Yeah, no, well. good. That's what I understand. Your legs have always, obviously this started at your arms, and so your legs have always been in much better shape than your arms. Yeah. So what's going on with the arms? Let's get to that. That's really been where this all started in you. And OG, is that you, Denise? That's Denise, right? Okay. Yeah. Go ahead, Brian. So do you figure if he does looks like it's like a 22? Yes. His finger extension is like a, yeah, 2 to 0. Yeah. Yeah, and the wrist extension is a 3 minus. Yeah. All right, that's what I remember from last week. All right, well, it's good seeing you, and we'll see you again. How often are we doing this? You're a slow progression, so we're looking at you 6 months for slow progression. All right, great. All right, well, you hang in there and let us know if you need anything. All right, bye-bye. I was reviewing your notes from last time that we took, and then talked to the team this morning before you came in, and I want to hear about your new and improved Dynavox. So I hear since last time, not only did we get some mechanical adjustments on the Dynavox, but you got the new software update. So I really want to know how that's working from either. A what? Oh, the miracle shot. I'm sorry. No, but I'm working on it. Yeah, go ahead. We'll get back to research in a minute, which is an important thing. But what about the Dynavox? Really? I'm going to email some of my patients around the country today. All right. Let's get reports from some of the team folks there. Who wants to start? One or the other. Okay. I'm just looking at what we did last time. Is he on any ALS relevant medications?
Next slide, please. So really, the results speak for themselves. We've gotten such good comments from the people who come to this clinic. Thankful that they can attend, as you can see, and really considering it a blessing to have a clinic close to them. Next slide. And I think what I would point out on this is that he says, with the telehealth connection, I got the care I needed without the time or cost commitment of travel. So I'm sorry that the video didn't work, but I would be glad to answer some questions if anyone has any.
If you have questions, would you please use the chat box to do that? And as we wait for some of those questions to come in, I just want to reiterate what a pleasure it was to work with the ALS Association, Sally in particular, and all of the ancillary services. The University of Kansas Center for Telehealth and Telemedicine and the HTRC assisted with that, and we were blown away by the cooperation, by Sally's just her passion of getting this done. And as you see, a 6-year journey was something that, you know, no one wants to really think about in terms of how long that takes to get something like that going, but persistence pays off. And the family members, I know, are grateful for the fact that this telemedicine clinic has taken place. So Sally, thank you for your persistence, your passion, and we really do, you know, love working with you guys. So do we have any questions in the chat box? Looks like we do. All right. Let's see. Do we know who all offers this? KU, Med, maybe, Mayo, maybe, or is it just the ALS Association at this point?
If we're talking about with ALS, there are, as I mentioned in the slide, there are about 10 other chapters that are using telemedicine to some degree. I think we are a first to use it this way, and in fact, we won a innovation award, a National ALS Association Innovation Award, because of the remote physician and local clinicians. But so I don't know if anyone else is using this structure, but as for telemedicine to help provide clinical care, we are there. The ALS Association, there are some chapters that do that. And I imagine that is going, from what I understand, that is happening in other disease entities as well. And I think it's just growing, probably growing by leaps and bounds, quite frankly, because the technology's there.
All right, great. How do you work with ALS clients who are not KU clients?
Well, that is the one thing on this, is that they do have to either have been to KU once for either a first opinion, first diagnosis, second opinion, or some kind of a visit, so that Dr. Barron and the team can actually have a record and be able to work with them and do follow-up and whatever needs to be done. So for those others, that clinical experience isn't there, at least through this. Now, we have other clinics throughout our service area, but as I said, that is one thing. We wish we had clinics within 100 miles of everyone. So we continue to add more clinical opportunities. But for this particular one, it does need to have that, they do need to have a records at KU.
All right, thank you. What was the biggest barrier to this clinic happening, in your opinion?
Well, as I mentioned, getting a neurologist. We tried to find a neurologist that would be a champion. You know, these clinics aren't easy to facilitate, and you really need, when we've all of us call them champions, but you need someone who is willing to really take that extra step and help assemble that team and make sure it happens. And that is what we feel has been lacking in many of our areas, especially in our rural areas. So that's why this concept of being able to access neurologists champions elsewhere and still give a clinical experience to places that don't have those professionals is an answer. So.
Thank you, Sally. Do you have just one cart?
You mean that the iPad goes on and goes around to the exam rooms? Is that, if that's the question, if it's the
Yes.
Robo Rick cart, we just have one. If we get more than, if this clinic grows, which it very well could, we have a lot of new patients in central and western Kansas. If this grows, we would probably need to add exam rooms and probably another one of the Medicarts. Mm-hmm. But we
Very
have
good. Thank you. Could you give more detail about the documentation process into Epic?
So, as I mentioned, we do not, we don't really have privilege in Epic as a nonprofit, and as our partners, our clinicians. But we are able to, we have 4 laptops that are in that go around with the clinicians when they are making those visits in the rooms, and the documentation from those gets sent to securely to KU for the patient record. We do work very closely with KU and the scheduling nurses and so forth, and the coordinators at KU and Dr. Barron's office to access Epic, but we don't access it directly. We have kind of a permission to do part of it, but not full access. Does that make sense?
I think so, and I think you described how, yeah, that you use a certain form that then that information is uploaded into Epic,
Right.
because you fax it to KU Med, is that correct?
We do it through a secure, yes.
Right, okay. All right, and I think that is all the questions that I see at this point. How soon, one more question. How soon do you break even? The cost versus the reimbursement.
Cost versus the reimbursement. Well, so let's say there's the traditional way of the clinic would be having the clinicians and the neurologist, the physician, in the same location, and the patient would be on a remote site. When that happens at this point in time, and Janine, maybe you can speak to this, right now the only person that gets reimbursed is the physician. The clinicians are not reimbursable at this point in telemedicine. In a regular clinic, they are, except for the social worker and the dietitian. But for the one we're doing, we are, because of the fundraising that happened, we are paying the companies to pay the clinicians on a monthly basis because of the partnership that we have with them. So it's a little different situation. If you're talking about reimbursement in a traditional one, then the telemedicine, with the telemedicine structure at this point in time, and I think that's going to change, the clinicians, the specialists, other than the neurologists, are not reimbursed.
Right, and that is just because the reimbursement constraints cause them not to be able to be reimbursed because they're not on their site. And so, yeah, the fundraising has to cover the reimbursement for these ancillary services. And until we can get the federal government and our state government to change those reimbursements, you know, they're going to have to continue to do that. My hope is that there is some movement in the federal government as far as reimbursements and being a little bit more inclusive with different services and where those services are performed. Telemedicine is not going away. We can only hope that reimbursement will follow well, I always say that it is very client driven right now. Telemedicine is very client driven. And so when clients say that they want these services, then and only then will our representatives pay attention and hopefully increase that reimbursement. One more question about Epic. So it is not a direct documentation into Epic, but it's an import. Is that correct, Sally?
That is correct. That is correct. Not a direct input into it.
Excellent. All right. I think that is it for the questions. Sherry, if we could allow me to share my screen now. All right. So thank you for your attendance and for all the questions. I really like it when it can be interactive like this, so thank you very much. This presentation has been part of the Heartland Telehealth Resource Center's webinar series. The next webinar is scheduled for Tuesday, May 5th, and we are going to hear more about telehealth and the opioid crisis. So make sure you mark your calendar and definitely make sure that you register for that one. Also, I would like to bring your attention to the National Consortium of Telehealth Resource Centers. They also have a webinar series, and in April, the topic is going to be telemedicine, how to do it right. And that training will teach participants how to do telehealth well and avoid common mistakes. They identified the core competencies through research in the University of Hawaii, and over 9 years and 20,000 telehealth sessions of experience, participants will learn how to engage patients and colleagues better, build stronger provider-patient relationships, create more private and comfortable treatment settings, and demonstrate compassion and good website manner, and communicate more clearly. So registration and further information about that will be out soon. Please look to your Heartland Telehealth Resource Center newsletter or go to www.telehealthresourcecenter.org in the next few days to be able to register for that. If you have questions, please don't hesitate to reach out. My email, jgracie@kumc.edu. And ask any questions that you may. If you have ideas of what you would like to hear next year in our webinar series, please let me know. Again, thank you for attending. If you need more information, don't hesitate to contact me. This concludes our webinar for today, and we look forward to seeing you virtually next time. Have a great day.